The evidence is based on a randomized controlled trial of 48 practices in Bristol and Hackney, where we, in half of them, put in place the training and support program and measured identification of women and their referral to specialist services. And what we found was that the program made a substantial difference in identification and referral, comparing those practices that got it and those practices that didn't. In the current economic climate, what we really need to convince commissioners is evidence of cost effectiveness and, even more specifically, cost benefit to the NHS, so they can make savings when they invest in a new service rather than increasing their budget. Bristol and Hackney were the two sites that we did the trial, the IRIS trial, and the essential difference wasn't between the practices in those two cities. It was in the championing of what we were doing within the primary care trusts. Bristol had a history of supporting services around domestic violence. Hackney didn't, and that made a difference in how easy we found it to position the trial and also get the service commissioned once the trial was over. The rollout of IRIS beyond the trial in Bristol and Hackney is part of an implementation program of selling, literally, the model to 12 PCTs, primary care trusts, or new commissioning organizations. The challenge is that these organizations are very new. In fact, they don't exist yet, because PCTs haven't stopped their commissioning function. And they are going to struggle with their budgets because the NHS budget is not going to cope with increasing demand over the next 5 years. The main effect that the new environment has stems from its uncertainty. We don't actually know what the new environment, particularly around commissioning, is going to look like in the NHS in the next couple of years. So we're trying to implement a model or a program without knowing what the levers are that really need to be pulled, and that creates for us quite a challenge. And A, because we're talking to people who will probably not have a job, in 18 months' time, which means that they're going to be risk averse, and B, because nobody really knows how the new GP consortia, which are going to be the commissioning organizations, are going to prioritize commissioning. And so our challenge is to show just how general practice friendly this particular program is, because we think that that's something that the GP commissioners may understand, and it's good fortune that our intervention is actually based around general practice. So we're going to play that for all it's worth.